Hi, everyone. My name is Shabir Musa, family physician in Johannesburg Health District, and we're hosting the AfroPHC, African Forum for Primary Health Care, the CPD program, which is also for Johannesburg. We have Dr. Sarah Swartboy, very fortunate to have her, great person. She's an orthopedic surgeon, and she's from Wits University, as well as Chris Barra. And we're going to get her to talk about an approach to joint pains, arthritis, from an orthopedic point of view. And I think that's a very interesting take as opposed to rheumatologists. So I'm hoping that we will get something very different. With that, I want to hand over, let me just stop this. I want to hand over to Dr. Swartboy. Dr. Swartboy, you can start sharing. And in the meanwhile, while you're busy with that, I'll just see if we can get a quick sense of who's in the room while you just start sharing. And then I'll just stop it in about 30 seconds. So Dr. Swartboy, you want to just share, and then we can start there. So please, guys, just fill it in and tell us where you are from and what your background's like, so that Dr. Swartboy has a sense of it. Dr. Swartboy would like it to be interactive. So she's going to call out your names and see if you will be able to respond to some of the little questions she has or scenarios and respond to it. So I think it'll be quite interactive and lots of fun. So let's get to at least 10 out of the 20 people we have in the meeting, and then we can start. One or two more just to add where you're from, and then we can start. One or two more of you. Okay, one more. Okay, great. Right, let me end the poll, and you can just see what we have is basically medical officer, mostly interns. We have most of them from Southern Africa, Gauteng. In Johannesburg, we have one from Tshwane. Great stuff. I hope that's been helpful to you, Dr. Swartboy.
Perfect, Prof. Perfect. Thank you so much. Let me start by introducing myself. As Prof has mentioned, I am an orthopedic surgeon within the Department of Orthopedic Surgery at Wits University, and I'm working currently rotating through Chris Baragwanath Hospital, Academic Hospital. So today I'm going to give you, it's my privilege to actually give you the generic approach to arthritis and how to essentially decipher which form of arthritis your patient presents with once they come to you with joint pain. Okay, so prior to us discussing any form of pathology of arthritis itself, I want to start by just discussing the synovial joint. In terms of the synovial joint itself, it's a diagonal joint, which means it's a freely mobile joint, and it's found at the ends of two adjacent bones which articulate with each other. The articular cartilage is extremely smooth, and it's nearly frictionless, essentially, and it covers the bone ends and allows the bone ends to glide on each other. Just underneath that, you have subchondral bone, which is dense bone, which actually supports the articulating cartilage, as well as just the structure of the bone itself, and it lies directly underneath the articular cartilage. Including that, you have your synovium, which is the inner membrane of your joint capsule, and it essentially makes what we call synovial fluid, which also helps lubrication of the joint, as well as ensuring that it remains frictionless. Thereafter, we have an outer covering, which is called the capsule, and it's a fibrous structure which allows stability and also maintains stability, allows to maintain stability of the knee joint itself. So this is a microscopic image of what we're just basically discussing. This is articular cartilage. Its composition is mainly that there of water, being about 80%. There's also collagen, which makes up about 8% of the articular cartilage. And there's the chondrocytes, which are the cells that produce the collagen, as well as proteoglycans, which ensure that there is sufficient fluid within the articular cartilage itself. Its function, as mentioned, it's smooth. It allows for a smooth surface over the articulating bones and for allowing free and painless range of motion. This is, my apologies, it's slightly blurred, but this is just a macroscopic picture of the femoral head of a cadaver, which shows a smooth articular cartilage with no abnormalities. It appears to be uniform, no defects, and that's essentially what a normal joint would look like. So in terms of the disorder itself, what exactly is arthritis? It is a chronic disorder, and it's characterized by softening and progressive disintegration of the articular cartilage. Depending on the form of arthritis that the patient presents with, they can be vascular congestion, they can be osteoblastic activities which result in subchondral sclerosis, they can be new bone formation, also known as osteophyte, as well as fibrosis of capsule that we just. So in terms of arthritis itself, we can divide it into that being of degenerative form or an inflammatory form. The degenerative form can be also further subdivided into primary osteoarthritis, also known as classic or idiopathic osteoarthritis, or they can be a secondary osteoarthritis. The primary osteoarthritis is also known as I mentioned, is idiopathic, which means that there's no identifiable cause, and it's common in the elderly population. The secondary osteoarthritis is usually due to an underlying condition, which we will go into get a little bit later on. In terms of our inflammatory causes of arthritis, you have your seronegative and your seropositive. Seropositive essentially means that there's a secretion of autoantibodies within the blood, as opposed to seronegative, where you find that there are no autoantibodies. I will go into and elaborate more into what autoantibodies we're discussing once we discuss the form of inflammatory arthritis. So in terms of our secondary causes of osteoarthritis, there are many different forms. Just looking at the topic itself, there are over 30 to 40 forms of secondary causes of osteoarthritis, but the main ones that we deal with are post-traumatic, avascular necrosis, neuropathic due to either diabetes or spinal cord injuries, etc., as well as our hemophilic arthropathies. So in terms of our inflammatory, we've mentioned that it is seropositive and seronegative. Our seropositive are most commonly seen is rheumatoid arthritis, systemic lupus erythematosus, and scleroderma. But there are other variants, forms such as vasculitis, etc. In terms of seronegative inflammatory arthritis, you have your spondyloarthropathies, your crystal deposition arthropathies, as well as infection. Those can be further subdivided into different forms. Our main form being on top is our ankylosing spondylosis. There's also the serotic arthritis. There's Rheumatoid syndrome, also now known as reactive arthritis, as well as an inflammatory bowel disease. Commonly known, I'm sure, to our interns, we have our gouty patients, as well as those that have pseudo-gout. Another form of inflammatory arthritis is that of infection. Septic arthritis is bacterial, fungal, viral. It falls under our seronegative inflammatory arthritis, as well as tuberculosis arthritis. So starting with our primary osteoarthritis, the definition essentially is regarded as a degenerative joint disorder with progressive loss of articular cartilage. It's seen mostly, it's a most commonly seen form of arthritis, and it increases in prevalence with increasing age. 80% of our patients at age 75 will be symptomatic. Depending on the literature that you read, They say that there's no sexual predilection in terms of gender. However, they do say that females present more often than males do in terms of management. In terms of the site that is usually involved, it can be the hip, knee, spine, most commonly involved, but as the disease progresses, it can involve the hands, the small joints of the hands, the wrists, and the feet as well. In terms of risk factors, they found multiple risk factors for osteoarthritis. That being said, they can be divided into systemic, local, or bone marrow causes of such as bone marrow density pathologies. Top of the list is that of genetics. So they found that there's a strong family history of familial osteoarthritis. So therefore, it's important when you actually discuss with your patient, it's important to find out whether there's actually, if their first generation family member has osteoarthritis. So in terms of the pathophysiology itself, on a molecular level, it occurs at the articular cartilage, the synovial joint, the synovium, as well as the capsule itself, and the bone. And it's actually progressive pathology. So within the articular cartilage, you have increase in the water content. And with that, you have increase with the increase of proteoglycan content as well. This results in loss of its integrity and elasticity of the articular cartilage, and then you have disruption of the normal organization of your collagen, which results in degradation and essentially softening and breaking down of your articular cartilage. With regards to that, you progress into synovitis, where you have thickening of your synovium, and that subsequently progresses into the exposure of your bone, and in attempt to essentially arrange or cause stability, there is osteophyte formation. So in terms of the clinical findings of osteoarthritis, it was initially previously thought that vast majority of patients who have a varus deformity have osteoarthritis. However, it has come to new literature has shown that a patient who presents with a knee pathology, they can present osteoarthritis can present with a varus or a valgus deformity. So it's not always, patients essentially don't read textbooks. So if a patient presents with a varus deformity, top of mind is osteoarthritis. However, it can present with the valgus deformity as well. So this is essentially, your patient will present with pain, stiffness, loss of function, and end stage would be deformity. In terms of the hands, it's important to look at the hands of your patient. As mentioned, it affects the large joints first, but as the disease progresses, you can also look at their hands and essentially see these unusual nodules and deformities of the digits. What we're seeing in this clinical image is essentially what we call Herbalist Nodes, and these are nodules that are formed at the distal interphalangeal joint, and when they progress to the proximal interphalangeal joints, they're called Bouchard's nodules. So as mentioned, this is just a depiction of the disease where you first have, it progresses from softening and fibrillation of articular cartilage, where you have loss of your articular cartilage with exposure of the subchondral bone, as well as thickening of the subchondral bone, and results in the complete exposure of your subchondral bone. This is basically just depicting what you would see in a knee of a patient, almost what you essentially would see on x-rays, where you have, firstly, if it's just involving the articular cartilage alone, all we'd see is just some joint space narrowing. As it progresses, you have joint space narrowing with the formation of osteophytes. And then lastly, you have complete loss of your joint space with large osteophyte formation thereafter. So radiographically, the cardinal signs of osteoarthritis are joint space narrowing, which occurs first. You have subchondral sclerosis, which is basically bone trying to remodel. You have osteophyte formation as well as your subchondrosis. This is an X-ray of a knee, which shows the tricompartmental osteoarthritis. As mentioned here, you can see there's large osteophytes involving both the knee joint as well as the patellofemoral joint. You have decreased joint space, involving most especially the medial side, and you've got your subchondral sclerosis as well as your cyst formation. So in terms of treatment for osteoarthritis,
Sorry, Sarah, do you mind showing the cysts in the previous picture?
Sure. Is my cursor visible?
Yes, we can.
Okay, so this over here would be a cyst here. So, okay. So they can be very small cysts, or they can be large. When they're large, they're called geodes. So this is a cyst over here. This over here is a cyst. These over here are cysts as well. Okay,
thanks.
All right.
And the subchondral thickening is, pretty evident at the margins of the joint.
Yes, so this is basically your reduced joint space. That's right. Your large osteophytes over there. There's osteophytes that are basically visible here as well. And this white line of here is your subchondral sclerosis.
Thanks.
Mm-hmm. So in terms of treatment, I really like this image that's depicted on the right-hand side, which shows that a vast majority of patients can be treated with non-operative management. And it's all a matter of educating your patient and having a dialogue with your patient, and starting from small non-invasive things such as just adding weight loss, a dietitian, giving the patient a walking stick or crutches. Anti-inflammatories play a large role in osteoarthritis, and should that not work, there's the addition of mild opioids. Literature recently has shown that the use of physiotherapy and activity modification has largely improved the quality of life of patients with osteoarthritis. Just with quadriceps strengthening and mobility, increasing the range of motion of the joints, they found that there's increased stability, and patients do quite well. The use of intra-articular corticosteroids, it is still performed. It's somewhat become controversial, but it's still a treatment modality that quite a few orthopedic surgeons still use, as well as rheumatologists.
If I can just quickly, I know you want to be interactive, but so I'll just intervene here and there. I've got osteoarthritis, primary osteoarthritis, and I just wonder about the presentation. It's in my family as well, like you've mentioned, and it shows it's actually been affecting the small joints, fingers and feet actually more than big joints. But as it's progressing, it seems to be involving the big joints. Is that an unusual presentation where people might come in sort of with almost Heberdin's nodules, but that's their real complaint?
I wouldn't say it's a completely unusual presentation, but the more commonly seen is that it affects the large joints first.
Right.
So the patients are usually, they come in with, once you actually start seeing the Heberdin's and Botard's nodules, you know that there's more, they probably have arthritis involving the hips already, but they are asymptomatic at that stage.
Yeah. And one of the things that I noticed was, the limitation. One doesn't actually always use your hands, and sometimes use your hips. So if you don't actually physically mobilize yourself, you don't realize a creeping kind of disability, loss of range of movement, and that I think is something I myself have realized. I'm not as vigilant to tell patients to take themselves to range of motion as often as they should.
Or something slight, or something even slight like stiffness, that you just ignore. You tend to ignore the stiffness in your knee or in your hip, and
That's
you
right.
just continue because it eases on its own. You just think, my knee's a little bit stiff, but after about 30 minutes, it's completely gone. So you ignore it.
Yeah. Usually in the morning you get up and, then you sort of move and it stops troubling you. So you just ignore it for quite a while. And the range of movement, it's only when I started finding I couldn't grip things that I then checked my range and realized, wow, I actually didn't realize how limited it's become. But its functionality is a lot later. And as clinicians, we ought to be telling patients to actually keep their range of movement a much better vigilance of their range of movement. That's what I realized in managing them myself. But the other thing that I also found quite interesting is that physios, I'm not sure exactly what they do all the time, but it tends to be sort of mobilizing and sort of heat and perhaps massage, various therapies. But I'm not sure that they use strengthening very much. Strengthening exercises.
They actually do. Physiotherapy plays a large role in the management. Without physiotherapy, I don't think that we get such good results. But they do quadriceps by improving the stability around the said joint. For example, if it's around
improving strength around the joint, and that builds up
muscular strength, improving the muscular strength, musculature. You improve the stability, and therefore you reduce the amount of pain. Not that you're going to essentially reverse the damage of any sort, but just by improving stability, it slows down the progression as well as improves the pain. As well as improves the range of motion there. So
in fact, I found myself, and this is very important because this is the commonest patient you find. But I found myself, and I think that's the problem as clinicians, we tend to say, do exercise if there's no physio nearby, or we don't have that kind of resources, which isn't available all over the country. So we tend to say, well, do exercise. But we tend to maybe say, oh, well, don't do high impact exercises. But to me, the distinction of aerobic, which can be even swimming, I suppose, if that's easily available, but telling people to do strengthening exercises using barbells, etc., and mildly, in other words, not jarring stuff, can be more beneficial than saying running or doing something that is probably like lots of walking. So building strength to me has helped me a lot more than things like running or walking a lot, or things that aren't necessarily strengthening. So just a thought, for clinicians to be aware that, and go to the physio and check on what they do, so that in the country you may be stuck in a small clinic or hospital where these are not so easy. Even as a general practice patient may not afford these things, you can give them some brief and useful advice on these. Thanks.
Absolutely, Prof. The things that I've seen in terms of, just from my experience, what the physios do, it's not like you said. They don't tell them to start running on a treadmill, because that will result in it's more discouraging, because what happens is that they do that and they come back with significant amount of pain. They're actually more so than they started. So what I've seen them do is they give them pamphlets where they say, okay, just do wall stands, where you basically the wall with your knees slightly flexed, and just and the small things like that. Where firstly you start with static kind of strengthening, and then move on from there. So yes, absolutely. Like road running on the treadmill can be jarring on the joints as well. But you do want them to actually load the joint, because articular cartilage relies heavily on basically bearing weight. You want them to weight bear. So with that, because of the fact that synovial fluid has lubricant, it has hyaluronic acid, you want it to be, and it's an avascular structure, so it does not have a flow for repair. So it relies heavily on hyaluronic acid and the lubricant and all the proteoglycans to actually diffuse through it. And the only way it can diffuse through it is by actually you weight, or the patient weight bearing on the said joint.
No, thank you. And I think, when you're looking at that, that's triangle you're showing us, I mean, most patients are you giving information and self-help, and that's really you telling patients what to do. And I think we get blasé saying exercise and alter your life, weight loss. These are not so easy for people who probably been battling for quite a while, enough to come to you then. And you need, the options are just simply to stick drugs into their face. You've got very little else. So if there's no physio, etc., on it, you now are literally at the limits, and you might consider injections, but that's not a good habit generally. So you really want to move them into that space of physio OT, and if they don't have that accessible, it's up to us to then manage and support them through that, that kind of mobilization and stuff like that. So I think it emphasizes the point of us clinicians, ordinary GPs being able to manage those things, even advising these.
And what and in a general rule, in terms of osteoarthritis or the arthritic joint, is that you have to do 6 months of non-operative therapy prior to any form of operative management. So we don't just essentially just look at a joint and say, oh, this joint looks terrible, cut it out, or change or resurface it, etc. We say first, okay, fine, irrespective of the patient's weight, irrespective of the patient's debilitating pain, we always start with first lose 10% of your body weight. If there's a high BMI, send them to the dietitian, send them to physios, send them to OT to see how can we make them more independent, what form of orthopedics can we use to assist them prior to us ever touching the blade. And I think, you've seen the numbers. Our waiting list for surgical management is up to 2025 or 26. So we rely heavily on our clinicians to start operations essentially on the baseline management of telling them, okay, fine, you have an arthritic joint, but to slow down the progression or to stop halt it completely, all that is required for you to do A, B, and C.
So in terms of regression or progression, if we in primary care are seeing the patient mildly without really major problems yet, we could probably do even better in terms of slowing the progression. So what's the impact of this sort of non-interventional, non-surgical type of space of slowing the progression? Is there some estimates or studies done on that?
There's been studies done on physiotherapy, Prof. That's as I've been stressing that physiotherapy and weight loss, the combination of those two can change a patient's life. We've noted there's multiple studies that were done in Cape Town and UCT, where they basically just said just a combination of physiotherapy, a patient who's well educated, essentially with their pathology, and that of weight loss can prevent all forms of operative management.
Okay, so does it sort of shift the curve of degradation out by any number of years? Did that come out in some specific? I'm just thinking of a tool. No idea. No, that's fine. It's just a tool to motivate a patient to say, doing this is important. This is what we're going to do, and don't let yourself land up with surgery, which might seem quick and easy, but isn't exactly fancy stuff. So useful thought. But anyway, thank you very much.
No, but I think the difficulty with us is that what we're finding is that we are the last stop. Orthopedics is the last stop, unfortunately. So once the patient is brought to our rooms, they've either failed non-operative management or they've never actually had any form of operative management. And the pathology is so severe that yes, we start them with non-operative management, and we hope that improves this in spite of how severe the pathology is. But the importance of this talk is to say that it actually starts with our clinicians who can
primary care right in the community. So we can explore this as a possible research piece, how we take that stuff you said was done in the UK, Cape Town, etc., and see if we can expand on that. So anyway, let me not stop you completely, but interesting idea of how to emphasize this sort of prevention element. Thanks. Let me let you proceed. Thanks, Sarah.
Thank you so much. So In terms of just the treatment that orthopedic surgeons usually offer is we can go from mildly invasive to complete joint replacement. In terms of, and this all depends on severity of the pathology at that time. So the treatment options that we have that are operative include that of arthroscopic debridement, where we just make small incisions within the knee, fill it up with saline, and just debride the areas where we find that there's softening of the articular cartilage. There's also what we call osteotomies, which means that we cut the areas. For example, if it's a varus deformity, we can actually rotate and cut and straighten the knee, where we are able to offload that compartment that's involved, and the patient will have will complain of less pain. This hip resurfacing is also something that has come back. I'm sure a lot of people know of the famous rugby player who had his hips resurfaced and is doing very well. And then girdle stone, where we resect the femoral head, is not done as often. That's why I put it as last, but it is an option. But the gold standard essentially for a severe osteoarthritic joint is arthroplasty or replacement, essentially. So another big topic is rheumatoid arthritis. So rheumatoid arthritis is an autoimmune disease, and it's cell-mediated. And what it targets in the synovium is a synovial joint is basically your soft tissue, which is your synovium. It's the cartilage, which is hyaline cartilage, as well as the bone. In terms of incidence in South Africa, there's a prevalence of 1%. And we found that it's more common in females by 3, with the ratio of 1:3. In terms of the sites, it's the small joints of the hands and feet that are initially involved, and it slowly progresses to involve the larger joints. So it's almost somewhat opposite to what you find in osteoarthritis. So in terms of the pathophysiology, what happens is that, as mentioned, there's an autoimmune response that occurs within the synovial tissues. There's a formation of pannus, what we call synovial pannus, which results from new vessel formation. You have something called synovial osteoblasts, which start secreting enzymes, which essentially can break down cartilage as well as bone. And from there, you get destruction of your cartilage and bone and result in deformity. So this is the picture on your right-hand side is basically when you do a joint replacement is essentially what you see. You see this hypertrophied synovial tissue with that's red and angry, has an angry appearance, and that is basically your pannus formation, which essentially accelerates your bony and cartilaginous destruction. So in terms of clinical presentation, they present with a slow, insidious form of pain, where they complain initially of this malaise or fatigue. They complain of morning stiffness, but it usually it lasts longer than an hour, and it's generally involves a small joint, and it involves more than one joint. So it's a polyarthritis. So it's more involves 2 or more joints, essentially. As mentioned, it's the hands and feet are a big target for rheumatoid arthritis. And this is where I'd like to ask a question, if anybody's available for me to ask. I would like to know.
If you just lift your hand, raise your hand, and I can allow you to talk. Go ahead, Sarah.
So let me put the question out there first, and then if somebody feels brave enough, they can just unmute themselves, Prof, or you can unmute them. I would like to know if there's anybody aware of the typical deformities that are found in a rheumatoid hand and wrist. Anybody?
Anybody?
Prof, I think you can just choose somebody to answer.
You're going to have to do that. All right. Jessica Aveen, do you mind doing that? Let me give you the opportunity to speak. Simiso as well, perhaps.
I'm not sure. Can you hear me?
Yes, thank you.
I think it's a boutonniere deformity, so I don't know how to pronounce. And then the other one is the swan neck.
Nice.
Yes. Yes.
Yeah.
That's absolutely so. That's absolutely correct. And the deformity that happened to the thumb.
I'm trying to remember. The thumb should be the boutonniere, and then swan neck, and then let me just see. Sorry, for which one? This picture now.
So yeah, so we can what we call it a Z deformity. You're right. It's
Oh, okay.
deformity, but we call it a Z deformity of the thumb. And then what happens at more proximal? What happens to the metacarpophalangeal joints?
So there's the ulnar deviation.
Absolutely, you get your ulnar drift, and at the wrist.
I'm not sure about the wrist.
So it goes there. It goes radially. So you basically also get a Z deformity of the wrist.
Okay.
That happens. Well done, Jessica. Thank you so much. So, as mentioned, this is a systemic illness. So it doesn't only limit itself to just the joint itself. So in terms of, I just put a diagram or a table here just to depict the vast majority of areas that can be involved, from your skin to your eyes to the mouth to the CNS and cardiovascular system, as well as respiratory and hematological. I'm not going to read out the disorders. There's many. There's Faulty syndrome. There's multiple syndromes that can actually occur. And it's important that a thorough examination is done for these forms of patients. This is just a clinical depiction of the extra-articular manifestations, looking at the eyes, looking at the nodules, important to examine the chest, the cardiovascular system, as mentioned, there's abdomen, all of that. So back in 1987, this was the diagnostic criteria that was first essentially implemented, and they had 7 criteria, and if you met 4 or more within the 6-month period, you essentially could be diagnosed with rheumatoid arthritis. However, things have changed. The American College of Rheumatology, or the European League Against Rheumatoid Arthritis, came up with a new criteria in 2010, and they basically divided into the joints that are involved, serology, the acute phase reactants, meaning your ESR and your CRP, as well as duration. And I think this is more holistic and makes more sense because it's a small joint disease that is seropositive and causes inflammation and is chronic. So if your patient has a score higher than 6, then it's basically a definition, or they fall into the criterion of being diagnosed with rheumatoid arthritis. So in terms of the lab studies that we do on our patients, should we think that they have rheumatoid arthritis, it's important to do your acute phase reactant markers, which is just CRP and ESR. In terms of rheumatoid factor, we still do it. We still do pull rheumatoid factor, but it's it's important to know that up to 20% of patients are actually rheumatoid negative. And a lot of the literature says that 80% of these patients are rheumatoid factor positive. However, in my practice, I think I've come across one patient who's had a positive rheumatoid factor. However, it's they are definite rheumatoid arthritis patient. So it's I don't know, it's scanty. I think that the rheumatoid factor is really less specific, for rheumatoid arthritis, but the literature says that 80% of these patients usually are rheumatoid factor positive. ICCP is more specific and sensitive to rheumatoid arthritis, and we rely heavily on that nowadays.
So if I may ask, so would you say that in primary care we should do a rheumatoid and CCP, or is a CCP more than enough?
No,
I mean, rheumatoid enough.
No, Prof. I think rheumatoid and CCP.
Because I think these questions, ACCP. The ACCP, you're saying the problem is that the accessibility in primary care, especially the public service, is not there.
Yes.
We'd have to justify it. But I think it depends on its need. So why is it important to have that? If you've got a rheumatoid positive, factor positive, do you think you need that CCP to say definitively?
We do need them because this is actually more towards the rheumatologist's point of view, but they needed to also assist them to look at the progression of the disease. So the new management in terms of rheumatoid arthritis is more aggressive. So it's, rheumatoid arthritis is regarded as a medical condition. And there's actually new algorithms that have come about that we start patients on disease modifying
DMARDs,
anti-rheumatoid DMARDs quite quickly, and we watched essentially the markers and how they improve or whether.
So I imagine in a primary care setting, we could probably do the rheumatoid factor, manage as we are, and then perhaps get a referral, sort of an assessment where a specialist facility can see whether that's adequate or not. And I imagine we would not necessarily refer a patient with rheumatoid arthritis unless the management was inadequate using non-steroidals. You don't just jump into DMARD straight away. So I imagine that would be a clinical indication.
No, Prof. So things actually have changed. So
what would you say is the specific change? Yeah.
So the specific change is that once you have a patient who has has confirmed rheumatoid arthritis, we start them on DMARD. Yes, who's seropositive. We start them on DMARDs as soon as possible, because the problem is when because you want to get disease if they're presenting to you with
you want to modify it.
You want to
starting them earlier.
Stop that process that is already that cascade of events that's already happening. You want to gain control quite quickly, and there's actually an algorithm that they have where every 3 months you actually do a reassess them, and then you tape it down. But you start quickly, but you tape it down quite quickly, and you monitor quite frequently, as opposed to waiting for deformity to take place, or for them to be debilitated, or for them to have X-ray changes prior to you actually starting DMARD. So the algorithm changed in 2013, and it was adopted in 2013, that we start patients on DMARDs relatively quickly, as opposed to
I agree. I mean, I think that things have moved on. I'm sorry if I appear a little dated, but I think the key problem for me, and I'm just thinking more in terms of the current public service primary care system. I imagine even in a GP in the private sector, I'm not sure that medical aids would allow a GP to be prescribing DMARDs. But I think in either setting, the reaction should be, listen, if I've got a seropositive rheumatoid arthritis patient, the need is to refer them immediately to get specialist support with that kind of DMARDs and treatment. I imagine, depending on the setting of funding, that we could start it. It's not impossible to get it going if one has the sort of algorithm management, as you've just said, and use that. But I wonder the payment system might be part of the issue, limiting the ability to manage in primary care. It's 1% of patients, so it's not really a lot of patients.
Yeah, it's not a large population of patients, but I think the take-home message would be is recognition.
Yes.
A recognition of
not letting the patient sort of muck around, like I've just said. Try them on non-steroidal.
Yes, trying them. It's recognition and initiation of non-operative management and referral as soon as possible.
True.
You know, that would be
Good.
the take-home message in terms of being of this talk essentially, or for primary healthcare physicians.
Good point. Thanks.
So now my question. So I can let me before I ask my questions, let me just discuss. No, let me ask the question first. Does anybody remember the cardinal signs of osteoarthritis, and how can you differentiate them from what we see in the image currently? Shall I have a look? Prof, I'm not seeing the.
Simiso, do you want to have a go? And if I can get it wrong, you can do it too. Jessica?
You can go ahead.
Good. Simiso, go ahead. Go ahead. You want a different
You can
voice.
go ahead.
Go ahead, Simiso, we're waiting for you. So you just give it a shot. What do you think? Answer Dr. Swatboy's question. What sort of features do you see of osteoarthritis?
Sorry, one would look at the joint space narrowing. If one looks at that, the juxta-articular sclerosing, those would be some of the things that one would be interested in when one is looking at OA.
Yes. So I absolutely agree with you. There's joint space narrowing. Yes, you said that there's, what else did you mention?
I mentioned the articular sclerosing of the bones because of the increased pressure, the juxta-articular sclerosing.
Yes. What else?
I think the erosion.
Shall I go back? Just let me go back to that picture of the knee.
Yes.
And you just have a look at this knee.
Oh, yes. Yes, the osteophytes.
What are these?
As well. Yes.
These large osteophytes and these
osteophytes, yes.
And these cysts that you are seeing here.
Cysts, yes.
So it's not very easy to differentiate, but if you look at a rheumatoid, I mean, even if you look at this hip over here, can you see the osteopenia? You know, if you look at this, the bones are quite thin and they're somewhat see-through. I don't know if you can see it here. This shows it very nicely where you've got very see-through, very thin bones. You've got the joint space narrowing. But of note, which is very important, is that you see minimal osteophytes. This is basically end-stage rheumatoid arthritis, where the bones are paper thin. However, there's not a lot of osteophyte formation. I mean, if you look at the previous picture, there were large osteophytes, especially on the lateral view. But if you look at this patient is has bone-on-bone contact now. There's no cartilage at all that's visible. However, there's not a lot of osteophyte formation, and so I think that's one of the compounding or significant things that you can use to differentiate osteoarthritis to rheumatoid arthritis is that, one, they're very osteopenic. They've got these small erosions that are very close to the joint line, and the joint space is narrowed. However, you don't see large osteophyte formation in rheumatoid arthritis.
Would you say that it's easy to make out, or do you think that really, if you're sitting in primary care, in 90% of the patients are osteoarthritis, you have to basically look at the X-ray, you might tell the difference, but the instinct should be do rheumatoid factors and ACCP and determine that first, so that you don't miss rheumatoid factor. And I think that's one of the little challenges I think I might take home is to be more vigilant, looking for this, even
Yes.
though it is less often.
Prof, I think it's very important that we're able to pick up rheumatoid arthritis. So sometimes it looks like a duck and it quacks like a duck, but it's not a duck. So so you might think that you're looking at a classic or a patient who says, "Oh man, I fell on my knee 10 years ago and it fractured," and you think it's a post-traumatic osteoarthritis. However, you know, there could be something more sinister. So we always advocate for bloods being done apart from just looking at the x-rays. We do.
And I mean, you'd be looking at the other bloods, which I think you're going to go into.
Yes, I'm going to go into
sort of
that.
look into that. Yeah. No,
So,
thanks. That's
yes.
useful.
So yes, so definitely looking at your ESR, your CRP. I mean, even if at a primary care level, that's all you have access to for at that time, it's important just to pull them, just to make sure that the patient has not, has nothing more sinister going, that's occurring.
So basically, if I may just quickly intervene there. So you're saying do the rheumatoid factor, even if the ACCP is not easy or can be done. And then you're probably looking at the possibility of seronegative arthritis to try and exclude some of the possibilities. Not so?
Yes, correct.
And secondary causes to osteoarthritis. Okay.
Correct. And so in terms of the management of rheumatoid arthritis, it's a multidisciplinary approach. And I hope I put the orthopod last, but it's the patient and the family, the rheumatologist, it's the orthopod, occupational therapist, as well as the physiotherapist. So these are all important players in the game, and in the game. And I think that none is more important than the other, but above all of them, essentially, is the patient and the family for support, so that the patient it's important that the patient has a clear understanding of the disease. It's important that the orthopod understands that it's not just the knee that's involved, but this is a systemic illness, because I think one of our flaws as orthopedic surgeons is that we tend to focus on just the pathology at hand. And for us, it's also a big learning curve to say that it's not just the knee. Once you make sure that the hip, once you make sure that this patient is pain-free, you can't just send them home and say, okay, fantastic, I've done my hip and goodbye. It's a matter of making sure that this patient is actually been optimized by the rheumatologist prior to us actually taking a knife to the hip or joint, making sure that they have had physiotherapy, because there's poor outcomes in terms of essentially not making sure that all these players are actually have come to the party.
In fact, if I may quickly ask the question, I think firstly, Simiso is a podiatrist, so we put him in this bit of a spot. But I'm sure podiatrists also face these kind of issues with joint problems. So Simiso,
yes,
sorry to put you in the spot. But Firu, Firu, who's a clinical officer from Ethiopia, asks, I think maybe an earlier question about physical exercise. I mean, do you think the same applies? Osteo and rheumatoid arthritis, osteoarthritis, rheumatoid arthritis. I'm not sure if you can just draw the distinction, or is it not, in terms of exercise? Same kind of approach. Perhaps as you're doing this, you can just clarify that for him.
Thanks, Prof. I think it will be the same kind of approach, because the joint degeneration will be one of those issues that one want to focus on. Of course, from the podiatry side, we're looking at the foot function, deformities, and all of that. But the approach will be holistic in nature to make sure that all the joints that are predominantly predisposed to deformation, degeneration are protected and actually rehabilitated to a point to make sure that the patient, regardless of the stage, they retain some level of mobility and self-function as well.
Yeah, great. No, thanks for that. And Sarah, your thoughts on that question for Firu as well? As you're going through this management goals, you can perhaps just elaborate on that for him. It was just in the Q&A, so I thought I'd just quickly raise it.
So I think I can just reiterate what sorry, is some
Simiso.
Miso has basically reiterated.
So,
But
yeah.
yes, yeah, I can just
So same thing, yeah. That sounds fine. I think that's good. Carry on. I don't want to stop you. I know time's running on, and I hope you got. Yeah, we don't want to lose the value you're giving us. Thank you very much for that. Carry
No
on.
problem, Prof. You can stop me at any time. So let me just jump through this. But I think the take-home message from the slide is basically to say that medical management is of utmost important. It's important to diagnose them early so that we can determine, like as mentioned, Prof, that I said that we need to do the blood work and serology to see exactly where at what level are they at in terms of their disease activity, and it's goal-directed therapy where we start DMARD quite soon to drop their acute phase reactants and the rheumatoid factor, etc., to the lowest level possible. Okay, so this is just a graph just to show what we use. Essentially, there's the drugs that we use in terms of anti-inflammatories is in any form of anti-inflammatory you choose is okay. We are moving away from the use of brufen because of the kidney involvement, etc. So we're moving more selective forms of anti-inflammatories. There's also that of paracetamol.
Examples?
So your what's
Diclofenac?
No, diclofenac is still it's
still much the same. I'm just wondering which ones are you referring to?
So there's Celebrex. There's two forms.
The new ones, the
Celebrex.
COX.
Yes.
The COX-2 inhibitors. Okay.
Yes. So Celebrex, and the other one escapes my mind now, but
yeah, the COX-2 basically.
Acoxia. So the Celebrex and Acoxia, Prof. So those are ideal. In state, we're having trouble essentially getting those, but
it's impossible actually.
Yes, but those are your ideals for your rheumatoid patients.
You say for rheumatoid especially.
Yes, because it's
the same problem would apply with a osteoarthritic patient. I mean, the same kind of challenges. Yeah,
absolutely. Okay. But what we found is that we rely heavily on our opioids, which is actually a disadvantage, with our because what happens is that it's an opioid at the end of the day, and what happens is that they form somewhat of a dependence on it, so it's hard to get.
The serious challenge is that all the interns are dishing out tramadol big time, and really they need to be careful about it. I think they're just pressing repeats all the time. Of course, there's little else more than paracetamol, so we can understand the frustration, but I think we just have to be wary of the trouble with it.
I can definitely say it's not only just the interns, it's at all our levels that we're left with not much else sometimes. Where you have patients who have physiotherapy once a month. So
exactly.
So
what value is you really have very little to work with. So if I quickly ask this, in the DMARDs, what are you commonly using? What's available within the public service? And what would be the challenges to using that in the primary care setting? Perhaps you can elaborate on that.
So first line that we are using, or what the rheumatologists are using, is the chloroquine. So chloroquine is the first baseline. But however, in terms of the biologics, they're using the Aticept. Quite common is the first line that I'm seeing. There's a lot of use of Arava, which is basically your TNF inhibitors, because they found that those are essentially a first line, and then they have the least side effects. They're the least side effects compared to your interferon inhibitors. So this is basically
So if one of the interns are stuck somewhere in the middle of Bundus, if they can get a hold of chloroquine, they could, given the management protocol you're suggesting, they could try it.
sorry, Prof. My apologies. It's chloroquine if it's
Or
SLE,
methotrexate.
and then it's methotrexate if
Yeah.
it's rheumatoid. My apologies.
Yeah, I've seen methotrexate being used in rheumatoid.
And it's
So you said
methotrexate.
chloroquine with SLE.
Yes, with SLE.
Okay.
SLE.
So those two drugs, they might be able to get a hold of it.
Yeah.
Those
So,
two
and
elements.
also in terms of steroids as well, steroids, we don't dish them out as much as we used to. So steroids are used in an acute phase where you feel that the patient has an acute a hot red knee, and their acute phase reactions are extremely high. So you can use steroids either oral or IV for a short period, but what we found, yes, the short bouts of steroids are used, but the automatic initiation of prednisone is no longer done. It's no longer prescribed. They are obviously because of the fact that the side effects are so dire, and we're seeing a lot of patients with avascular necrosis of the femoral head due to it. So then, in terms of the concerns of the pharmacological management of rheumatoid arthritis is the risk to sepsis. So where we come in terms of that is that when a patient is on disease-modifying drugs, we have a protocol as to when to stop their drugs, and so it's usually generally depending on the type of drug that they're using. We found that stopping it about 2 to 4 weeks prior, and reinitiating prior to any form of surgery, and reinitiating it 1 to 2 weeks thereafter. So that's essentially because what we want is that we want the patient to actually have initiation of the normal inflammatory cascade, so that they can actually go into visibility, so we can prevent wound sepsis and wound dehiscence. We want the actual initiation of the neutrophils of the immune system to prevent sepsis, essentially. Also important. Sorry, I've just mentioned that when to stop the treatment prior to surgery. But yeah, our biggest concern as orthopedic surgeons is the risk of sepsis. So just wanted to mention, in terms of, just to run through some of the smaller forms of osteoarthritis, as mentioned, is avascular necrosis. Avascular necrosis occurs in areas where there is some form of compromise to the blood supply, be it a retrograde blood supply, such as in the scaphoid, or where there's in the talus, where there is a bone that is significantly covered with articular cartilage, and small areas where where blood can actually filter through. But the large sites are generally the femoral head, the head of the humerus, the scaphoid, the talus, as well as the lunate. Those are the areas where we see it most commonly. That does not mean it only can occur. They can occur within the knee as well, or any area where there essentially is a bone. So this is a mnemonic that's come about to assist you to essentially help remember the causes and risk factors for avascular necrosis. But the big five for us, essentially, especially in South Africa, is one, steroids. Steroid use. We found a lot of especially on the East Rand, there are quite a few primary healthcare physicians who prescribe steroids for pain. It works for pain, but the resultant cause of. Beg your pardon, bro?
Yeah, no, I'm saying it helps, but that's crazy. Anyway.
Yeah, no. So a lot of our patients who come in with avascular necrosis say that they've been on prednisone for now I had a bit of knee, etc. And it works. The prednisone works very well for pain, it's because it is a form of anti-inflammatory. It does actually help, but the destruction that it causes is quite dire. So our big five are steroids, alcohol, trauma, HIV, and smoking. So those are the big type that we've come across. Did I mention HIV? My apologies. HIV.
You said it. 5.
Yes. Yes.
Yeah, HIV
so the
was one.
HIV. So there's been debate whether it's actually the HIV that causes the avascular necrosis or the drugs thereof. Because there's been a large paradigm shift from patients, from the outlook of ARVs has changed, that a lot more patients are actually on ARVs than not. So we've actually found that irrespective of them being on ARVs, they still present with avascular necrosis. So there's been quite a bit of debate as to, is it the HIV that causes the AVN versus is it the drugs thereof that cause the condition?
What's the prevalence of avascular necrosis in South Africa?
Prevalence of avascular necrosis, Prof? Sure.
Not very easy to tell. It's not I mean, on Barra, you'll see many, but globally, I mean, in the country, it's probably not as large, not a large thing.
No, it's not a large thing. I think it's very difficult for me to say the privilege just off the top of my head, but I would say it's about 5%. 5%. It's
of anyone with joint pain in the hip.
Yes, Prof. It's one of I think because of HIV, the combination of HIV and trauma, avascular necrosis is one of the most common forms of arthritis that we treat. You know, so it's large. It's most definitely larger than the rheumatoid patients, but not as large as obviously our osteoarthritic groups.
No, I think relating to the rheumatoid arthritis is helpful. It is quite a problem. So clearly we need to be aware of it.
So this is just a picture showing the classic features of avascular necrosis, where you've got severe flattening of the femoral head. On the image on my right-hand side is the left hip. Basically, you can see that the femoral head is completely gone. You've got the classic joint space narrowing. You've got this plastic, abnormal-looking acetabulum, and you've got large. You've got subchondral cysts, complete collapse of the femoral head on the right-hand side, and you actually got secondary osteoarthritic changes, and that's essentially the end stage, where if you start seeing that it appears to where there's osteophyte formation, that's essentially the end stage of your avascular necrosis.
So if I can quickly ask you, Sarah, how long do you think to the end of it? I think people seem to be dropping off slowly. If we just give them a time, I think we'll get them to take us to the end. How long do you think it'll be to complete? I think we were supposed to have an hour. I'm just wondering, we're a little over the hour.
Okay, so, I'm just going to what I want to do, Prof, is actually just take them to just a quick approach. Just give me 10 more minutes.
All right, that's fine. At least people have an idea. And then the slides will be available. So if you skip over anything, that the detail will be there. It's already there on the website. So feel free to skip anything that you think they can just read. Great.
Okay, so we've basically discussed our seropositive arthritis, and then in terms of your seronegative, I'll just quickly whiz through these. Is your ankylosing spondylitis, and basically what happens with this is that there is the collagen gets destroyed and it's basically replaced by bone. So these patients present with ossification signs or forms of ossification of the spinal cord, of the sacroiliac joints, and also of the costovertebral areas where the ribs essentially articulate with the sternum, and so they've got problems with chest expansion and breathing, and they have deformity and lack of range of motion. So this is just a clinical picture of a gentleman showing that he's basically appears to be standing straight. However, his hips are flexed in trying to compensate for his severe stiffness of his spine. And with him bending over, you can see that his spine is he's got loss of his abnormal lumbar lordosis. Another form is your serotic arthritis, which classically you see that they have a rash on their skin, and it's a salmon-colored rash over their extensors with fitting of the nails. Important to do x-rays where you see what they call classically a pencil pointing cup kind of form of dactylitis that they have. This is basically your Rheumatoid syndrome or reactive, where the mnemonic is can't see, can't pee, can't bend the knee. I remember that from varsity or from med school days. There's an easy way to remember this form of patients, but they also fall under that group where they have essentially have urethritis, conjunctivitis or uveitis, and arthritis. So just in terms of the gouty, the crystal deposition, you have your two forms. You've got your gout and pseudogout. They are different in terms of where they occur. Usually a gout is usually, I'm pretty sure everybody knows, it's usually what they call podagra, where they have involvement with the first metatarsal phalangeal joint, as opposed to your pseudogout, which usually affects the knee. And in terms of aspirating the joint and looking at under the microscope, the shape of the crystals, firstly, the crystals are different. In gout, you have your uric acid as opposed to your calcium pyrophosphate. And then also the form and kind of crystal that is formed. So these are just clinical pictures that show your gouty tophus gout and the areas where it actually does occur. And I thought this was a lovely picture showing calcium chondronosis, where you have a calcium deposition within the articular cartilage, and that will basically differentiate it from gout. And so this is what I wanted to show one more time. Just your arthritis can be divided into degenerative and inflammatory. In terms of your degenerative, you've got your primary and your secondary causes. You've got your seropositive versus your seronegative. Your seropositive, as mentioned, is your rheumatoid arthritis as SLE and the other forms of autoimmune diseases. And then your seronegative are the different the spondylopathies, your crystalloid deposition and your infections. And then from there, you go on to ankylosing spondylitis, your psoriasis, your Rheumatoid syndrome. And then in infection, it can be further divided into your septic arthritis as well as your TB. So I think I'll end it here, Prof. If there's any questions.
No, you've done an excellent job and you've actually finished earlier. So, and I think you're a wonderful teacher. Thank you. You've really gone through some really graphic stuff. I'm sure everyone benefited greatly from that. We've kind of answered questions as we've gone along. I don't see any more questions. If people have anything that they'd like to add or comment on, feel free to raise your hand or use the chat or the Q&A. But thank you, Dr. Swatpoy. This is excellent stuff. We really appreciate you taking of time to spend with us on a Thursday afternoon. And I think everyone's benefited greatly. I don't see any more questions.
My pleasure, Prof.
That's wonderful. And thank you, department. I think they really are very committed to supporting primary care, and we really appreciate that. So just share that to them. Okay, so. Seemingly, yeah, thank you. And seemingly there are no more questions, no more comments. So let's stop there. There's CPD every week, and you'll see that on the AfroPHC website. So feel free to go and look at that. And we're going to put them out a little bit earlier than is, and hope more people join. So thank you, Dr. Swatpoy. Thank you all.